Hey everyone, today we're jumping into a skill that you're absolutely going to use, blood donor selection. And look, this isn't just about memorizing a bunch of rules. It's really about clinical judgment. It's about protecting two people at once, the donor who's right in front of you and the patient who will eventually receive their blood. So let's get right into it.
So here's our game plan for today. Think of this as your crash course, your virtual blood bank rotation. We'll start with the why we screen in the first place. Then we'll move into the initial physical checks, tackle the absolute no's versus the temporary wait a whiles, and then we'll finish by putting it all together to make that final clinical call.
So picture this. You're in the clinic. A potential donor walks in. They're ready to help, but all the responsibility is on you. The assessment you make in the next few minutes, well, it's the first and most critical link in a chain that can literally save a life, or if you get it wrong, cause serious harm. The stakes couldn't be higher. So let's make sure you're ready. So what is the core principle behind all of this? It's really simple. It's a dual responsibility. First, you have to make absolutely sure that the act of donating, giving up almost half a liter of blood, isn't going to harm the person giving it. And second, you have to guarantee that their blood is going to be safe for a recipient who could be incredibly vulnerable. It's a two-way street of safety.
Now, here's the formal definition that underpins everything we're about to do. These criteria aren't just arbitrary rules pulled out of thin air. No, they're evidence-based standards, meticulously designed to maximize safety on both sides of that transfusion equation. Every single thing we're about to discuss today ties directly back to this one fundamental concept. All right, let's get practical. Before you even dive into the detailed medical history questionnaire, you've got a set of baseline physical measurements to check. Think of these as your first-pass filters. They let you know right away if a donor's even physically able to be in the chair. Okay, so here's our first clinical scenario. A young, healthy-looking student comes in, wants to donate for the very first time. They're eager to help, but when you weigh them, they come in at 48 kilograms. That's about 106 pounds.
So what's your call? You're the one making the decision. Does that weight meet the standard? And here's the tricky part. Does the answer change depending on where in the world you're practicing? Just think about that for a second.
And here's the answer. In the UK, it's a no. The minimum weight there is 50 kilos. And the why behind that is just basic physiology. A standard donation is about 470 milliliters. And if you take that much blood from someone with a lower total blood volume, you're seriously risking things like fainting or even hypovolemia. But if you're practicing in India, this donor could give a smaller 350 milliliter donation since the minimum weight there is 45 kilos. It's a perfect example of how guidelines adapt to balance donor safety with the needs of the local blood supply. Okay, on to the next case. A 45-year-old man walks in, says he feels great. You do the quick finger prick test, and his hemoglobin comes back at 130 grams per liter. So is 130 grams per liter good enough? And hey, does his gender matter here? What if this was a female patient? And just like before, how do the international guidelines compare? This check is absolutely crucial because the last thing you want to do is cause iatrogenic anemia. That is, anemia you caused in a perfectly healthy donor. So as you can see from the table, in the UK, he would actually be deferred. He wouldn't be able to donate. The minimum for males is 135 grams per liter, while for females, it's 125 grams per liter. Now, that difference is there to account for baseline physiological variations between sexes, and it ensures the donation doesn't tip someone into an anemic state. So a female donor with that exact same reading of 130 would be good to go. Meanwhile, in India, the standard is 125 grams per liter for everyone, so he'd be totally fine there. It just goes to show you that both gender and your location are key factors.
All right, now we're moving into the permanent deferrals. These are the non-negotiables. These are conditions or events where the risk to a recipient is just considered lifelong and, frankly, unacceptable. These are the hard stops. Now, here's a tricky one that might catch you off guard. A donor tells you they received blood after a surgery way back in 1995, and it happened while they were living in the UK. They tell you they feel fantastic, haven't had a single health issue for decades. So does that event from so long ago really still matter? Is this a reason for a permanent, lifelong no? And the answer is no, they absolutely cannot donate. This is all because of a very specific public health precaution. Due to the theoretical risk of transmitting variant Creutzfeldt-Jakob disease, or VCJD, that's a prion disease, anyone who got a blood transfusion in the UK since 1980 is permanently deferred in many countries. This is on top of the more common permanent deferrals you might think of, like a history of HIV, hepatitis B or C, or intravenous drug use.
Okay, let's shift gears now to temporary deferrals. Think of these as the not right nows. These are for conditions or exposures where the risk is temporary, it's transient. So the key question here isn't if they can ever donate, but when.
Our next case is a patient who is recovering really well from a major operation. She had a total knee replacement 8 months ago. She tells you her surgeon has cleared her for all activities. So is donating blood one of them? What's that specific time frame you need to have in your head for a scenario like this?
If you look at our timeline, you can see that major surgery requires a full 12-month deferral, so our patient needs to wait another 4 months. And the thinking there is to give her body plenty of time to fully rebuild its hemoglobin and iron stores after the stress of surgery. This visual also helps lock in other key periods, right? Like 28 days for live vaccines to make sure there's no virus in the blood, and a really important 6 to 12 months for things like tattoos from a non-regulated place, which covers that critical window period for detecting bloodborne viruses.
Okay, time to put it all together. Because let's be honest, real-world donors rarely walk in with one single simple issue. Your job is to systematically work through what can be a really complex history to land on a safe and correct decision. So here is our final challenge for today. We have a 28-year-old woman, and she has several things going on. She got a tattoo 3 months ago. She's currently breastfeeding her child. She just finished a course of antibiotics last week for minor infection, and her hemoglobin is 127 grams per liter. A lot to unpack there. This is it. This is where the rubber meets the road. You've got multiple variables, and they all need to be assessed. So take a moment, run through the criteria we've talked about. Is she a go or a no-go for today? What is your final clinical judgment? Let's break this down systematically, just like you would in a real clinic. Okay, step 1, her vitals. An HB of 127 grams per liter is above the 125 minimum for females, so check. She passes on that count. Step 2, medications. She just finished antibiotics. That right there requires a 2-week deferral to make sure the infection is completely gone and there's no lingering bacteria in her blood. So that's reason number 1 to defer. Step 4, her physiological state. She's breastfeeding. That's a deferral for the entire time she's lactating, plus some months after, and that's to protect the mother's own iron stores. So that's our second, completely separate reason to defer. So even though the tattoo is a factor, we already have 2 clear no's on the board. The final decision is a clear deferral for today. So what we've seen today is that donor selection, it's a dynamic process. It's about investigation and clinical reasoning. It's about understanding the story of the person sitting right in front of you so that you can ensure the safety of the story that's yet to be written for the person who receives their amazing gift. The real question is, what will your next clinical decision reveal?